Hello everyone, welcome to the TutorMed channel where everything medicine is simplified. So in this video, we will look at some practice questions and case examples on the liver panel interpretation to consolidate our knowledge. You will find this video very useful if you have already watched the video on the LFT interpretation. If you haven't, I suggest you do that before watching this video. You will find the link to that video on the top right of your screen or in the video description below. Kindly support the channel by going through the LSSC. I mean, like, share, subscribe, and then leave your comments in the comment section. Alright guys, let's get started. So for our first few questions, we will do some MCQs. Question 1 reads, the following statements are true except A. The liver is the largest organ in the body. B. Blood supply to the liver is only through the hepatic artery. C. Portal tracts in the liver are composed of a hepatic arteriole, a portal venule, and a bile ductule. D. Blood leaves the liver through the hepatic vein. Which among these four statements is false? If your answer is B, then you will be right. Indeed, the liver is the largest internal organ. And remember this diagram of the lobule from our previous video? Yes, it shows that the liver has a dual blood supply from the hepatic artery and the portal vein. In fact, the hepatic artery only supplies about 25% of the blood. A chunk of the blood comes from the portal vein. The hepatic arteriole, portal venule, and then the bile ductule forms the portal tract or the portal triad. I remember we said that the blood flows through these fenestrated blood channels, known as the hepatic sinusoids, into the central vein. And the central veins of all the lobules drain into the hepatic vein, which subsequently drains into the inferior vena cava, and from the inferior vena cava, drains into the right atrium. And so option B is the false statement among the four options. Question 2. The best liver function test is A. ALT/AST, B. Alkaline phosphatase or ALP, C. Bilirubin, D. INR. If option D is your answer, then you got it right. Of the above, only the INR is a true test of the liver's function. It examines the liver's ability to produce vitamin K dependent clotting factors. Factors 2, 7, 9, and 10. Enzymes, like we said, are tests of injury. ALT/AST are markedly elevated in hepatocellular injury, while ALP is markedly elevated in cholestatic injury. Bilirubin can be elevated in the setting of a normal liver function, and so an elevated bilirubin is not necessarily equal to a deranged liver function. And so option D is the best liver function test. Question 3. AST and ALT are the best markers of severity of acute hepatitis. A. True. B. False. If you think it's a false statement, then you will be right. Although elevated AST and ALT are the hallmark of an acute hepatitis, the severity of the disease really depends on the preservation or not of the hepatic synthetic function. and so hepatitis is severe if and when there is evidence of liver dysfunction, evidenced by a prolonged PT or INR, or even development of encephalopathy. Question 4. BT is an 18-year-old student who became ill 1 month after returning from school. Her initial symptoms were fatigue, anorexia, and nausea. She noticed dark urine and became jaundiced a few days later. She denied having fever, chills, abdominal pain, or changes in bowel habits. She has been previously healthy and did not have any previous abnormal labs. So based on the history, take as many diagnoses that can fit her clinical presentation. A. Acute viral hepatitis. B. Drug-induced liver injury. C. Primary biliary cholangitis. D. Hereditary hemochromatosis. E. Cholelithiasis. If your answers are acute viral hepatitis and drug-induced liver injury, then you would be right. An initial approach to the workup of any liver disease is to determine the acuteness of the symptoms. It is useful to think of liver disease as being either acute or chronic, and then based on the expected pattern of injury, they can be grouped into acute hepatocellular injury or chronic hepatocellular injury, or acute cholestatic injury or chronic cholestatic injury. Viral hepatitis is one of the most common causes of acute onset of jaundice, and it fits acute hepatocellular injury. For example, hepatitis A infection. Another common cause is a drug-induced liver injury. And so obtaining a history of use of over-the-counter medications, herbal remedies is important in this patient. Primary biliary cholangitis is a chronic cholestatic liver disease, and in general, patients are asymptomatic until about age 40 to 50 years, and the onset of symptoms is usually insidious, not acute, like in this patient. And so the acute presentation in this young patient made this diagnosis unlikely. Hereditary hemochromatosis is a chronic hepatocellular disease in which excessive iron is deposited in the liver and other organs such as the pancreas and the kidney. It is more common in males than in females because females lose iron monthly through menstruation. And so you would expect that females, if they are predisposed to this condition, would have symptoms usually after menopause. And so the acuteness, the age of the patient, and the gender representation made this diagnosis unlikely. Although a common bile duct stone can give you an acute cholestatic liver disease that may be associated with jaundice, it is almost always or usually accompanied by severe right upper quadrant pain, which was absent in this case, and so it made cholelithiasis also less likely in this patient. Alright, so on further questioning, the patient reports no unusual food ingestion, no other person in the dormitory has become ill, and she denied recreational drug use, including alcohol. She is sexually active with a steady boyfriend. She has been using oral contraceptives over the past 6 months, and her last menstrual period was 10 days ago, which was normal. On examination, she was icteric but afebrile, alert and well-oriented. Hysteresis was absent. There was a mild tender hepatomegaly, about 2 finger breadths below the costal margin. The liver edge was smooth. There was no shifting dullness on percussion. Spleen was not palpable. So initial tests were ordered and these were the results. WBC or white cell count was 6.2, which was within the normal range. The other white cell differentials, including the neutrophils, eosinophils, etc., were also normal. She had a normal HB of 12, meaning she was not anemic, and she had a normal platelet count. Now let's take note of the following and then put these values on a paper because we will revisit them. Total bilirubin was 8.3, which was about 7 times higher. Please take note of the number 8.3 for total bilirubin. Direct bilirubin was very high, 4.7, over 20 times the upper limit. AST was 5,700, ALT 6,200, ALP 110, which was what? Normal. But the AST, ALT were all abnormal. And so before we look at the questions that follow this case presentation, let's try and interpret her liver panel based on the information given. First, we begin with the enzymes. So she had an ALT of 6,200. The upper normal limit was 35. AST of 5,700. Upper normal limit of 35. ALP of 110. Upper normal limit of 114. So we need to determine if she has a hepatocellular injury or a cholestatic injury pattern. To determine that, we use the R value. The R value is equal to ALT value, which is 6,200 over its upper normal limit, which is 35, all over the ALP value, which is 110 over its upper normal limit, which is 114. And when we compute this, it comes to 183.56. And since the R value is more than 5, it suggests a hepatocellular injury pattern. The next thing is to find the Diritis ratio. Diritis ratio is the same as AST over ALT. So that would give us 5,700 all over 6,200. And the answer came to 0.91. Remember, a Diritis ratio of greater than 2 is suggestive of an alcohol-induced liver damage. And since this is less than 2, alcohol-induced liver damage is unlikely. And then we come to the bilirubin parameters. She had a total bilirubin of 8.3 with an upper normal limit of 1.2, and then a direct bilirubin of 4.7, upper normal limit 0.2. To get the indirect component, we just subtract the direct bilirubin from the total bilirubin, and that would give us the indirect component. But to calculate the percentage direct bilirubin, we would have 4.7, which is the direct bilirubin, all over 8.3 times 100, and this answer gives 56.6. And since this is more than 20%, or some school of thought say more than 50%, this is a conjugated hyperbilirubinemia. Then we come to the albumin, but unfortunately, this question did not give us the albumin level. But since we are thinking that it is an acute damage, our best bet is that albumin is likely to be normal. Alright, so let's move to the next question for this case scenario. Which of the following tests are indicated? Choose all that are correct. A. Gamma-glutamyl transpeptidase. B. Hepatitis A serologies. C. Hepatitis B and C serologies. D. Anti-mitochondrial antibodies. And E. INR or prothrombin time. You'll be right if you chose options B, C, and E. Yes, you need to do hepatitis A B and C serologies because all are common causes of acute hepatocellular injury, which she has. INR, or prothrombin time, is a measure of the synthetic function of the liver, and it is typically deranged in acute liver injury. It should be monitored in patients with severe hepatitis, which this patient is likely to have. And also in patients with acute liver failure, INR needs to be monitored. GGT is not indicated in this patient because the ALP was within normal range, and so there is no need to differentiate whether it comes from the liver or from other sources. Anti-mitochondrial antibody is a serological marker for primary biliary cholangitis, which is a chronic cholestatic liver disease. However, this patient has an acute hepatocellular liver disease. And so the appropriate tests were sent and the patient was instructed to come back to the hospital the following day for follow-up. Her liver tests over the next 2 days are as below. Her initial INR of 1.1 was borderline normal, but by day 2, the total bilirubin, the AST, ALT, and again the INR progressively increased, and by day 3, the hepatocellular enzymes reduced, but the INR kept on deranging, and the bilirubin, as seen, was also increasing. The viral serologies showed that she had an acute hepatitis B infection, which is most likely sexually transmitted from her steady boyfriend. Hepatitis A and C were unreactive, evidenced by the fact that the IgM anti-hepatitis A antibody was negative, and then the hepatitis C antibody was also negative. To understand the interpretation of her Hep B serology, kindly refer to our video on the interpretation of the Hep B profile. Alright guys, please do not forget to subscribe to our channel, like and share our video, and leave your comments in the comment section. Now, based on the information we've been given, what is the most appropriate management at this time? Kindly select all that apply. A. Since the aminotransferases are decreasing, continue OPD management and plan to check her liver tests weekly. B. Admit the patient for close monitoring. C. Start lamivudine. And then D. Perform or do a liver biopsy. If your answer is to admit the patient for close monitoring, then you would be right. This patient has a progressively rising INR and bilirubin levels, indicating the onset of liver insufficiency with the possibility of fulminant, which is very severe hepatitis. This then requires immediate hospitalization with close neurologic assessment for the development of encephalopathy and close monitoring of the INR. And if a transplant team is available, the primary care physicians need to call for a consult and possibly do a standby workup for liver transplant. Although the aminotransferases are decreasing and patient doesn't have encephalopathy, then there is evidence of liver insufficiency, which indicates an impending fulminant liver failure, and OPD management has to be discontinued. Lamivudine therapy is not indicated in the acute setting. A liver biopsy is not indicated in any acute hepatitis, particularly when the etiology is clear. The only indication perhaps for liver biopsy in acute hepatitis is when a treatable condition like CMV hepatitis or EBV hepatitis is suspected and was not confirmed by serology. In that instance, a liver biopsy may be indicated. Good. And so the patient was admitted, monitored closely with a plan in place to fly her out of the country for a liver transplant if necessary. Over the next few days, her condition remained stable and she didn't develop encephalopathy. Her tests are shown below. So by day 4, the total bilirubin had reduced from 16.4 on day 3 to 14.9. The hepatocellular enzymes were steadily reducing, and then INR improved from 1.8 to 1.5. And through till day 11 on the ward, the bilirubin had come down, although it was still above the initial total bilirubin, which was 8.3. The AST-ALT had come down drastically, and the INR had drastically improved to 1.1, which was borderline normal. Alright guys, the patient has been on the ward for 11 days and we know her current state clinically and then her lab investigations. So what is the adequate follow-up at this point? And choose as many that apply. A. List for transplant. B. Discharge her with follow-up visits in 1 to 2 weeks. C. Check her Hep B serology up to 6 months after her acute episode. And then D. Start lamivudine since the process appears chronic. If option B and C were your answers, then you are totally right. The patient is clearly improving and so can be discharged home, and there wouldn't be a need for a transplant. Hepatitis B can evolve into a chronic infection, and so there is a need for hepatitis B profile to be done or repeated after about 6 months. Lamivudine should not be started because chronic hepatitis B by definition is the persistence of the surface antigen for about at least 6 months, and the patient has only had this infection for a month, and so we do not know whether it will progress to a chronic infection or it will quickly resolve, and so there is no indication to start lamivudine. Question 5. A 75-year-old man is being evaluated for a possible prostate carcinoma. On physical exam, he had paraparesis, a power of 3, in both legs, and as part of the workup for possible surgery, he had a liver panel done which showed a high ALP, but all other parameters on the panel were normal. 1. How will you tell if this ALP rise is hepatic in origin? And 2. Assuming the ALP is non-hepatic, what will explain its rise in this patient? And so for question 1, you will be able to tell that this ALP rise is hepatic in origin if there is a concurrent rise in the serum GGT. And question 2, if the ALP is non-hepatic in origin, then what is likely to explain its rise in this patient is a possible bone metastasis. Since ALP is found in bone, then any lytic lesion in the bone will spill out ALP into the serum, making ALP rise without a concurrent rise in GGT. Question 6 and the last question. The two main patterns of liver injury are A. Hepatocellular and cholestatic. B. Hepatocellular and necrotic. C. Cholestatic and obstructive. D. Neoplastic and cholestatic. I'm sure by now everyone is thinking, obviously the answer is A and there is no need for an explanation. Very good. Alright guys, so before we end this session, let us acknowledge the source of most of our questions. So most of our questions came from the US Department of Veterans Affairs on their topic, viral hepatitis and liver disease website course. And this is their link. You can log on to see the questions after looking at this video.